only one. Country survive. Do well. Well, conquer. Alright, so we're going to start off with malaria. This is going to be one of the biggest things that you guys really need to be aware of. Why? Because when we deploy, this is one of the things that you guys really need to brief your soldiers about. You need to tell them the importance of why they should adhere to the chemoprophylaxis that they generally don't take. And the law. Okay. CDC has a great site for this thing, so you can always go to cdc.gov/malaria. One of the other things that we also do is travel medicine. Once you guys go out and start working. So if someone comes to you and they tell you they're going to go to some country, make sure you look it up and see what kind of stuff they have. Give them vaccines if they need the vaccines, and give them any prophylaxis that they may need. In this case, it would be prophylaxis for malaria. Technically an infectious disease, cycles of chills, fever, sweating, caused by protozoa, plasmodium species. There's 5 different ones that we have. All they do is, once they get in, they invade your hepatocytes initially. They propagate inside your hepatocytes, your liver cells. Rupture your liver cells, go out and go look for red blood cells. Once they find the red blood cell, they get into the red blood cell, they propagate. Once they get too big in there, they just rupture that red blood cell. You have red blood cell fragments all over your body, which causes the spike in fever, and we'll go over that. Okay. It is transmitted to humans by the bite of a female Anopheles mosquito. We do have Anopheles mosquitoes in the U.S. Okay. But remember, mosquitoes are not born with this stuff. They have to bite somebody who's infected, whether it be animal or human, to get infected themselves, and then they go around biting other people and they're infecting other folks. This little block right here basically has everything you really need to know about malaria. That one little slide there. About half of the world's population basically lives in a malaria-ridden area. There's a lot of people that can have or be affected by malaria. Here's some of the things that we're going to cover here. Okay, there's a lot of people that get sick, so it does cause a lot of clinical problems that the places that they get sick don't or can't take care of. The folks that are working that get sick can't work, so it causes economic problems in some of those underdeveloped countries. And this generally happens in a lot of those poorer countries or underdeveloped regions around the world. Okay, there's some numbers from previous wars of people affected by malaria. Our numbers have drastically dropped to more so double digits for our last encounter that we had. Instead of 50,000 or 390,000. Remember, this is a stat slide, so it's not going to be in the test. Africa accounts for 90% of the malaria cases and deaths. Sub-Saharan Africa accounts for 90% of malaria cases and deaths. One of the biggest reasons why this is, aside the infrastructure for medical, right, is that P. falciparum, which is one of the species of malaria, which is the worst species of malaria, is endemic in that area. Okay? This is the one that usually kills most folks. And here it tells you usually among children under the age of 5. So here are your 5 species. There's 156 named species, but these are the ones that we're going to talk about. P. falciparum is the worst one. Okay? If you want to highlight one that you really need to know, P. falciparum. Okay. Vivax and Ovale, we usually put together. They have slightly milder symptoms, slightly go a little bit longer, and those are the only 2 that have a hypnozyte stage. And that is something to probably highlight, and we'll get to it when we get to those slides, but Ivox and O'Valley are the only ones that have a hypnocyte stage. And what that means is, once it gets into that liver cell, right, it can go dormant. And if it goes dormant in there, it's not going to affect anything. It's not going to cause your immune system to go and try to kill it or anything. It'll be asymptomatic. And you may be asymptomatic for years before this thing decides to pop back out and cause you malaria. So you could have left the endemic area 5-10 years ago. And if you do have this sitting in your liver, it may pop back out. Right? And we'll talk about the post-chemoprophylaxis that's very specific for that. It's one of the reasons why we take it. Then you have P. malaria, and then P. nawasi, similar to falciparum being the worst. Nawasi we've seen nawasi more in Malaysia, and generally the macaque monkeys. So people that are around that little area with the infected macaque monkeys tend to get it. Generally, we don't see it very often. Okay. So we're really not going to talk too much about Nawasi, but usually you'll see that in Southeast Asia. Now, for falciparum, the reason why it is the worst one, we'll probably cover that in some other slides later, but falciparum is also the only one that creates a little sticky gel on the fragments of the red blood cells. Right? So once they leave the hepatocytes and they invade the bloodstream, the merozoites go into the red blood cells, they propagate, they get so big in there, they rupture the red blood cell, it creates fragments of red blood cell all over the place, right? But in doing so, as it propagates inside the red blood cell, it releases a little sticky gel. That little sticky gel goes onto the fragments of the red blood cell. And those fragments end up sticking to the walls and sticking to other internal organs, liver, kidneys, heart, brain, locking things up, okay, causing more damage. So that is one of the reasons why falciparum is one of the worst ones, and it has the highest mortality rate out of all of them. But here's some facts. It is the Anopheles mosquito, female type specifically, right? We are just a reservoir, okay? Just like some other animals are just reservoirs for when this mosquito bites you. Nothing big. Okay. Climate, rainfall type climate. Remember, how do mosquitoes continue to breed? Stand in water. Whenever they're standing in water, those eggs can lay eggs and continue to go on, right? So usually those tropical rainforest areas are really huge for these things. So South America, Africa. Temperature, it's about 77 degrees, so it's tropical weather. But the big thing to look at is that altitude. Right, so we have to remember as we go up, everything gets thinner, decreases oxygen. Same deal for that mosquito. That mosquito usually doesn't go about 6,000, 6,500 feet. So, say for example, you were going to Cusco, Peru, where it leads you to Machu Picchu. Usually you don't have malaria up there because these mosquitoes can't make it that high up. Alright? Unless they get to ride on something. So usually malaria at higher altitudes, very, very rare. Okay? Right, so here's the species, and here it's giving you the breakdown of where you generally find them. Okay? Malaria is usually endemic in Africa, India, and other areas of Southeast Asia, North and South Korea, okay, Mexico, Central America, Dominican Republic, if you guys have gone to the all-inclusive resorts over in the Dominican Republic, they have had travelers come back from vacation with malaria, right? Because it is endemic in the Caribbean. Keep that stuff in mind when folks are going on vacation. Right? Here in the U.S., we usually don't see it. We do pretty well with it. But remember, we do have people that come from endemic areas here. We do have travelers that go to endemic areas and then come back. And if one of the anomalous mosquitoes that are here tend to bite one of those people, then we can tend to spread the malaria. Malaria is a reportable disease, so if you do find somebody with malaria in the U.S., you need to let the health department know because they'll contact the CDC. Here's a little path. The sporocytes are what comes from the regurgitation of the mosquito. Okay? So, mosquito goes and bites an infected person. It goes and it harbors inside the gut of the mosquito. Then the mosquito comes and bites you. Okay? There's 3 stages of this malaria life cycle. Okay? You have the mosquito stage. That's where they go and bite someone and then they get infected. That's what we call the sporogenic cycle. Then we have the human liver stage. That's the exourethric cycle. That means it's outside the red blood cell. Right? That's when it actually goes into the liver. And then you have the human blood stage, or the urethritic cycle. That's the most important stage, the urethritic cycle. And within that urethritic cycle is when they actually penetrate the red blood cells. And when they penetrate the red blood cells, they go in there, the sporocytes infect the liver, they mature the schizons, they break out of the liver, the schizons go, convert into merocytes into the red blood cell, they continue to propagate, they rupture the red blood cell, come out, and you continue to find more red blood cells, and you continue to affect more folks. Okay. Generally the way it works. Right? But the key to this is each one of these species has a specific timeline that it replicates inside the red blood cell and ruptures the red blood cell. We don't use that as a diagnosing tool. We can use it as a diagnosing tool, but it is not definitive. So we have to quantify it. Okay. Here it tells you got a small percentage of turning gametes, they undergo sexual reproduction. That's the rest of the path that we're talking about. But the important part of this slide right here to highlight will be the p-Vivax and the p value in the hypnozyte form. And as we mentioned earlier, when they come in, they go to your hepatocytes, and there they continue to mature before they rupture out into your bloodstream. Here, Ovali and Vivax have the option, their choice, of going dormant. If they go dormant, your body's not even going to recognize it because it's buried inside of the hepatocyte. Okay? And it can lay dormant for as long as it wants, or once your body drops its immune system for some reason, it may pop out because your body can't contain it anymore. So that's the important piece to remember with Vivax and Ovali. Now, why do we think that's important? Somebody tell me why you think that's important.
Autoimmune comes out.
Say again?
Comes out during autoimmune.
Autoimmune issues, okay. Anybody else? Yes, ma'am.
I mean, when the infection returns, then they are then going to be able to spread it again, wherever they're at.
Okay, the infection returns, they can spread it again. Anybody else want to take a stab at it? No? Why this is important? So what do we do before any of these folks go out? when they go, what do we do with any of our soldiers before they go, what do we do? Prevention is key, right? Prevention is key. So we try to put them on some sort of chemoprophylaxis so that they don't get infected. But do our soldiers really take that stuff every day? Right, because we're down to doxy now for malaria prevention. Do they? No, the answer is no. And we don't need to sugarcoat stuff. Most of the soldiers don't take it. It was awesome when we were taking methylquin because it was only once a week. But we stopped doing that because it was really expensive and they found some psych issues. So they stopped taking, so they stopped giving it to us, right? But the importance of this one is when they come back, we have to give them post-prophylaxis, okay? The standard malaria medicine that we give folks will not get rid of this if you have it. The standard medication that we use, because what we're going to do is we're going to give you doxy for another 30 days once you come back to make sure you don't have anything going on in your bloodstream, right, from the malaria. But we're going to have to give another medicine called primaquine. Primaquine acts inside your liver to kill this 5-axonal value in case you have it, or in case you have anything else in your liver. Okay? That's why it's kind of important. And we also need to make sure that our soldiers understand the importance of this. History is critical. Okay. HPI in infectious disease is extremely important. Okay? Said at the beginning, and I'll say it till the end. HPI is extremely important. Sometimes these guys are going to show up to you here, stateside. Like you're stateside, how do you have a letter? Okay? That HPI will get you to that point. Okay? Should you ask the right questions? Where you been? When was the last time you left the country? Were you in an endemic area? Did you actually take the chemoprophylaxis medicine? Did you take any post-chemoprophylaxis medicines? Did you take them appropriately? Okay? There's a lot of questions that you should be asking to make sure that you can figure out what's actually going on with that patient. Now, the incubation periods are a slightly different story here. Your falciparum goes for 12 days, Vivax 14, no Valley 17. So those are still within that same little window. Okay, your malaria is 28 and your NOS is 9 to 12. Just remember, you should be 14 to 17 days for incubation period. If it chooses to remain, go at the moment that you get infected with Ovaldi or Vivax. If not, it's going to go in the dormant stage. Now you just sit with it. Right? Malaria, 28 days is the longest one. And the reason it's the longest one is because when it invades your hepatocytes, it moves really, really slow. Once it ruptures out of your hepatocytes and it goes into the bloodstream, it looks for those red blood cells, it gets into the red blood cells, but then it just sits there and it moves and propagates really, really slow. It could be weeks to months once they get into that red blood cell for it to actually start causing any issues, because the replication of this is so slow. So a lot of times, you end up with a chronic issue because your patient is asymptomatic until those red blood cells develop enough to start causing problems with malaria. With malaria. Okay? So we have to be careful with that. It's very subacute. All right. So here's your periodicity. Every 24 hours, we know that Noesi goes into the red blood cell. It propagates enough that it ruptures it. So every 24 hours, red blood cells are going to rupture. Okay? When the red cells rupture, it triggers cytokines and it makes your immune system like pop off. Right? So you're gonna get a spike in a whole bunch of symptoms. Cold symptoms, heat symptoms, pain symptoms, okay? Because of the rupture of those red blood cells. Now, Noestes every 24 hours. Falciparum, Vivax, and Ovali are usually every 48 hours. And then malaria is every 72 hours. Right? Malaria the longest just because it's the slowest one to replicate inside of those red blood cells. And this just goes back to that exo, or to the urocytic cycle, when they invade those little red blood cells. So here, I like the little charts, because here it kind of thoroughly shows you what actually happened, right? So here's all those little neurocytes out there. They're looking for red blood cells. Here's your red blood cell. Penetrates your red blood cell, causes a little definitive ring. Then it goes in there and starts growing and growing and growing. So eventually it ruptures again. And when it ruptures, it causes you to spike that fever right here. Okay? And as it spikes the fever, for falciparum specifically, it's a very slow degradation for you to come down. So look, we got you probably got about a day and a half before you start feeling better after you rupture, and then all of a sudden you just drop and you start feeling better. So at this point you feel better, okay? But when it ruptures again, 72 hours later, you spike the fevers, okay? So falciparum, every 48 hours, right? Whereas we talk about Vivax and Ovali, it's the same. It's every 48 hours, right? When it ruptures, right down here, right, it causes you to spike that fever and get a whole bunch of symptoms. But look at the difference in recovery when you have falciparum, right? It's a slow recovery, and then you get better, versus you spike that fever, and then you recover really fast, and then you feel good for about another 2 days or so before you spike it again. So there's another big difference between some of them. The amount of time that you actually feel better between those paroxysmal spikes. And for malaria, it goes every 72 hours, right? 1, 2, 3. So here you spike, and then you actually feel better pretty quickly after that, right? And then you feel good, and then you spike again. Right? That's every 72 hours. And within that spike, you'll have the cold stage where you will feel an intense cold, radio shift, and that only lasts for about 15 to 60 minutes. Okay? Then you go into a hot stage where you have that intense heat, dry burning of the skin. Maybe you have a throbbing headache, and that can last anywhere between 2 to 6 hours. And then you go into that profuse sweating stage where your temperature starts going back down. And that usually lasts 2 to 4 hours. And after you finish all that stuff, usually you feel pretty tired and pretty fatigued. Okay. So initially you can have some flu-like symptoms, fever, headaches, malaise. It's all stuff from the spiking of the fever, right? Heat, cold, and recovery stages. Now, this little bottom part here where it says immune, partial immune, non-sterile, and innate. Okay, there's a lot of people that live in these endemic areas. Once you get bit and you get better, that does not mean that you're fully immunized. You may have a little bit of coverage for a little while after, but it goes away. So you can get bit again and get malaria again. Not to mention, you can get a different species of malaria, right? You're not protected for any of this stuff. So immune-wise, you have it for a little bit, but it goes away. If you live in those endemic areas and you repeatedly get malaria, you end up with partial immunity, right? So you may have a little bit of protection behind you where it may not be as bad until your body takes over and then gets rid of it, right? Then you have a non-sterile aspect of immunity. And what that is that you have partial immunity, but your body doesn't completely eliminate the parasite. Right? So the parasite's still in your system, but your body is controlling the parasite load, so it makes you asymptomatic. No symptoms, so that non-sterile immunity. Okay? The problem with being asymptomatic with non-sterile immunity is that you can still spread it. So mosquitoes can still bite you because you have that viral load in your system. And it can still spread to other folks. All right? Now, this innate immunity is a little bit on the more genetic-based side. Not going to get extremely into it as much, but that's more based on whether you're G6PD dependent, whether you're sickle cell trait versus disease, or if you have a Duffy group, or you lack that Duffy group. I don't know if you guys covered any of this stuff in ClinCore, or in ClinLab, I'm sorry. But specifically for the lack of Duffy group, it's the lack of Duffy group is a little protein that sits on your red blood cell. Right? A lot of people in sub-Saharan Africa have this, okay? It's part of their genetic makeup. Right? The thought process is that they've been exposed to this stuff for so long, their body's trying to protect themselves from malaria, which means since they lack that little Duffy protein on their external portion of their red blood cells, malaria cannot attach to those red blood cells and get in and kill them. Okay? So it decreases their ability to get malaria. So more genetic issues to kind of protect certain races. Okay? Non-immune patients, that'd be us. Okay? As travelers, if you go to an endemic area only get bit, you're gonna get really sick. That's just all that means. And then your last statement technically just tells you that malaria, PFAS syndrome is the worst one out of all of them. Yes, sir.
Quick question. Does a lack of Duffy also explain why sickle cell patients are like resistant to
Say that again?
Does the lack of Duffy explain why sickle cell patients are kind of resistant to malaria?
Okay, so did everybody hear the question? His question was, does lack of Duffy proteins protect you because you have sickle cell?
Yeah, because I know like sickle cell patients are resistant.
All right, so those are two different things. Okay, lack of Duffy is one thing. Sickle cell disease and trait are what you're talking about. Different. Okay? Different reasons for having it. Now, you have to differentiate sickle cell disease from sickle cell trait. Sickle cell disease does not give you protection against malaria. Sickle cell trait, on the other hand, will give you some significant protection against malaria. Those are different genetic issues on different alleles of your genetics. Different than Duffy. Good? And I think at the end of this, it'll show a little study that they did with sickle cell trait versus sickle cell disease in consideration for protection against malaria. And I think it shows that sickle cell trait does give you some protection versus one that has nothing versus actual sickle cell disease where you don't. Right. Just remember that the sickling effect allows your red blood cells to not live as long as they should. Okay? It also causes other damages in your system. But because those sickle cells don't last as long, it doesn't allow the malaria to really propagate well. But it also causes you other medical problems. Right? Versus sickle cell trait doesn't really cause you as many problems, and it also keeps them from getting to your system as easily. Okay. Why is falciparum so bad? It can cause microvascular sequestration. Okay. The little sticky stuff can block up arteries, can block up vessels. It can. The other difference with falciparum is that it is innocuous for all red blood cells. Most of these usually attack one specific type of red blood cell. This one does all. Immature, mature, late, bone marrow immature. All the red blood cell types that we have, falciparum attacks. Okay. Which causes you even more severe type issues. Now, that's sticky stuff that the red, that falciparum does when it ruptures those fragments. If it does get to your brain, that is what we call cerebral malaria. And so there is a possibility that it can also affect your brain. Okay. Tons of parasites from falciparum because it affects all your red blood cells. So it makes more parasites than a lot of the other ones as well to attack more red. And because all your red blood cells are breaking, you end up with anemia. Okay. So here, severe manifestations, cerebral malaria, that's actually what affects your brain. Severe anemia. More so with falciparum, just because it attacks all red blood cells, not specific red blood cells. And that renal failure there, or red blood cells adhere to renal microvasculature, you can attribute that to falciparum, or more specifically to Nowlasi. Nowlasi is really, malaria, P. malaria, is one that can be attributed to the renal failure. Okay? Because that one is so slow in propagation, it can deposit immune complexes that start forming because of its speed within the red blood cell. And it tends to kind of like the glomeruli in the kidneys. So when we talk about nephrotic syndrome, when we talk about more renal failure, we would talk more about malaria, and then falciparum would be under that for causing nephrotic syndrome. And all it's really doing is just causing inflammation and damage to the glomerular filtration system. So complications. Who's got problems with this? Pregnant patients. Pregnant patients have problems with this. Increases risk of mortality to babies. Right? You can't pass it on to the baby. All right. If you do have it early, increase risk of low birth weight, fetal loss, okay, premature birth. Okay, so that's splenic rupture with vivax and ovale. Splenic rupture can happen with all of them. Okay. So we kind of sort of target vivax and ovale just because it takes quite a while for these things to pop up. And when they do, they're also somewhat a little bit slow. So as they pop and break, and pop and break, and pop and break, the liver, the spleen goes to a workout. Right? And there comes a point when that spleen can no longer clear out all those red blood cell fragments. Right? This is for all of them. Kind of target these guys specifically. But it gets so much debris from the fragments of the red blood cells that it starts to enlarge because it's being overworked, trying to clean out your blood. So, although it's rare, there is a possibility of splenic rupture. Does not happen overnight. This stuff usually takes weeks to months. And so it'll be quite a while before that spleen starts popping up. Or when you're looking for your physical exams, that you're going to really see the enlargement of the spleen initially. Okay. want to be smart, there's a couple of other things that kind of sort of seem like malaria. Can we differential? Should we decide to do some labs? Here's a whole bunch of things that you may find. Obviously, you're finding anemia, right? Because your red blood cells are being broken up. Hemoglobin's going to be gone. Okay, the inadequate level of oxygen in your body is going to make your body switch from aerobic to anaerobic metabolism. And when that happens, your body generates lactic acid. So you're going to have a lactic acid increase. Thrombocytopenia, because your red blood cells are dying, right? You don't have eosinophilia with this. These guys go into your red blood cells. So with eosinophilia, usually you attack your T2 helper cells, right? In this case, malaria is attacking the T1 helper cells. So with T1 activation and immune response, you don't usually get eosinophilia, okay? It's usually T2 because T2 is with parasites and allergies, okay? Here, T6PD deficient. So two things that we kind of sort of do in the military nowadays: check if you're sickle cell and check if you're G6PD. If you are either, you should have red dog allergy tags. Okay? That will guide us in how we treat you. Okay? That will guide us in how we treat you. So if your folks, soldiers, are T6PD or sickle cell, make sure that they do have those red allergy tags. The other thing to be extremely concerned with is for any of those folks that are G6PD, you have to be careful if you're going to treat them with quinine medication. Right? Teach them with quinine medication, you may cause them to have hemolysis, which would be another problem that you're going to have to take care of. So ensure that you check before you give them any kind of quinine medication. Okay. Here's a whole bunch of labs that you can do that will probably be paired. You can look for malaria. If you're looking for malaria or calciferum, you may have some renal issues. And if you have renal issues, you're going to end up with acidosis of some kind. The liver's being jacked up, so it gets really, really bad right out of whack. You may end up with some jaundice, hyperlipemia, hypoglycemia, elevated aminotransferases, all liver stuff. So choose to look up some other labs for this thing. Really what you want to do is look at your viral load for parasites inside the individual person. Okay? The other thing you need to do is just follow it to make sure, and really follow it with thick and thin smears to ensure that the parasite load is decreasing. Thick and thick smears are the gold standard for finding malaria. Okay. Here it says parasitemia, and then it says greater than 5% neutrophils contain malaria pigment. Malaria pigment is known as hemoglucin. It's a brown or blackish crystalline substance that forms as a byproduct of the digestion of hemoglobin from those red blood cells. And we can track some of that stuff inside the system. But if you want a gold standard, your gold standard is your thick, thin smears. You have to do it more than one time, do it multiple times, generally 12 to 24 hours apart. It's very simple. You just take some blood, drop it on a slide, drag one side, leave a little drop on the other, and just take a look at it under the microscope. Okay. Now, I will tell you, the best time to draw the blood for these guys, if you're going to do your thin and thick smear, would be right after they spike a fever, right? Because we know pathophysiologically that when they spike the fever is when those red blood cells rupture and you have the most neurocytes in the bloodstream. That's kind of what you're looking for when you're drawing that blood because that's what you're gonna look for, those little parasites under the microscope. Okay? But do it as soon as they finish, or as they spike that fever. Okay? Gives you your best opportunity. And there it tells you your thick smear, 20 times more sensitive, but your thin smear is less sensitive, which you can speciate a little bit easier. This is one of those clinics overseas kind of looks like, right? So look, they have a little microscope right here. All they gotta do is do the little thick thin smear and look it under the scope and they can tell you what you got. Right? I'm sure they probably have a patient right behind this curtain right here that they're working with. So keep in mind where the majority of these folks live and the endemic areas and what they have available to them. This basically just shows you how to do a thick and thin smear. Put a drop on a slide, drag another slide over it, and put another drop on the other side of the slide, and then just take the slide and put it on the microscope. It's a real simple process, all right? I am not going to test you on this, so don't worry about the slide. Just understand, it's very simple to do. Okay? It will look like this. All right, really easy, thin, thick. Differentiate for speciation. Okay. They do have a rapid dipstick test. This is what you got, this is what you got. Rapid dipstick only goes for falciparum and for Vivax. The problem is that you get a high negative one. And the problem with this is if you're negative, you still have not ruled out malaria. Okay? And if you're positive, then you really need to ensure that you're positive, and if it does come back positive, then you would do a thicker thin skin for verification. If you do have PCR, by all means, use PCR. But remember, a lot of places over there don't have PCR. Okay, we have what we call Biomax. If these are not in your MAS set kit outfit when you deploy, you guys can order this and take it with you. Okay, so you at least have something that you can say, hey, look, this is what we're going to do. Because you guys don't have microscopes. If you look at that sensitivity specificity for falciparum, it's actually pretty high there. Okay, pretty high. And then the one for Vivax sensitivity starts dropping a little bit, but for specificity it's pretty high. Okay. But even if it is positive, you really should confirm with that thicker thin smear. Okay, always consider malaria in endemic environments, even if the patient is asymptomatic. This is what that looks like. This is your control. This is falciparum, and this is Vivax. These are your positives down here. It's real easy. You take a blood drop from your patient, put it on there, wait 15 minutes. You get your answer, yes or no. Real simple. And obviously it's really targeted towards falciparum because falciparum is the worst thing. Okay. So prevention versus treatment. This is ID. So for ID, the key is prevention. Right? For ID, the key is prevention because if they don't get it, you don't have to worry about treatment. Right? And then your patient actually is better off because they're not sick. Okay? How do we prevent this stuff? None of the meds that we have are 100%. Okay? None of the meds that we have are 100%. We don't have vaccines. Okay? There are some trials going on over in Africa that have some vaccines. There's one called Muskie Rex. But they're in trials, we still don't have it. Make sure you use all your protective stuff. The Army gives you stuff, right? The uniform is embedded with permethrin. Right? Use DEEP. Army gives you DEEP for free. Okay? They tell you to Wear long pants, keep your sleeves down, decreases the skin exposure to those little mosquitoes and bite. So if we can use prevention, hey, by all means, use prevention. Okay? This is all the areas of the world that are affected with malaria. As you can see, it's probably about half the world, right? So look at that picture. Okay. Now, this is the key here. This is one of those, you need to know this slide. Okay? We'll probably be on the test. I haven't written it yet, but it'll probably be. Okay. So these are prevention and prophylaxis medications. We used to use mefloquine, which is the one all the way at the bottom here. Here it says CNS side effects no longer widely used worldwide. We don't even use it in the US anymore. Okay. It would be great, once a week, not a problem. We used to use malodoril. Okay. So right here in the middle. That one was pretty good too, but it was really expensive. So ultimately, we've fallen back to using doxycycline as your preventive medicine for malaria in the little malaria endemic area. Okay. Now, depending on how you take, this is the easiest way that I found. Depending on how you take the medication is when you should actually start the medication. So if it's an everyday pill, doxycycline is an everyday pill for prophylaxis, you should at the minimum start it 1 to 2 days before you go into the country. If it is a once a week pill, then you can start it 1 to 2 weeks before you go into the endemic country. That's the easiest way for me to remember it. Now, I will tell you, higher headquarters for wherever you're going to go to is going to tell you what you're going to use. Do you have any MSC officers in here? Yes. Okay. So you guys can look in Viax or Travex, right? And you guys can see, hey, this is what we use over there, but then this is what your surgeon, your AO surgeon is telling you to use. So remember, sometimes some of those things don't match up with what the CDC is telling you, what the World Health Organization is telling you, versus what your higher headquarters surgeon is telling you. And so just keep that in mind. Okay. So generally we use Doxy. Make sure we tell our patients, hey, it's going to cause you some skin sensitivity, which means you're going to be able to burn easier. But if you keep your sleeves down, keep your pants down, like that. Keep your leg, part of your leg pants down. Right, the sun won't burn your skin, you might be okay. You wear your hat, cover up your face, don't get sunburn on your face. Okay? You know, if you're not wearing your boonie, make sure you cover the back of your neck with some sunscreen. Cover the back of your hands with some sunscreen. If it is going to hit your face, make sure you put some sunscreen on your face, especially if you're light skinned. Okay? Because that makes you more prone to sunburn. The other thing you may want to tell them is make sure they eat something or put something in their stomach before they take the pill, because it may upset their stomach. A lot of people stop taking Doxy because it upsets their stomach and causes them GI symptoms. But if you tell them to eat something, it'll decrease that GI symptom side effect for them. Okay? The other piece with females, they may call them vaginitis. Why? Because this is an antibiotic. Kills stuff indiscriminately. And if it kills stuff indiscriminately, it kills the good bacteria inside the vaginal canal as well. So things to keep in mind when you're instructing your patients on taking the medication. All right. Now, another issue that we have with malaria, okay, we use this right here, chloroquine, as specifics are depending upon what part of the world you go to, is whether or not it is chloroquine or quinine resistant or sensitive. If it is resistant, any of the quinine medicines that we have for malaria will not work. Okay? And that you have to look on those CDC maps and World Health Organization maps, and then or the Sanford's Guide, the Yellow Book. Any of those places will tell you the areas of the world that are chloroquine resistant or sensitive. That's also going to drive what you give for prevention. Okay? That will also drive how you treat these patients if they get sick. All right? So we don't really use this much just for the fact that there's lots of resistance in different parts of the world. And doxycycline's a lot cheaper. And this one protects you against everything. Okay? All right. So the last one, if you notice, I have not talked about Primal. When someone comes back from deployment, you should give them 30 days of doxycycline after they leave the endemic area, right? So once they come back home, they should take it for 4 weeks. Still 1 pill a day, right? It's going to make sure that anything floating around your system does not get into your red blood cells. That's what doxy's supposed to do. But you also give them 14 days of terminal prophylaxis, and that terminal prophylaxis is going to be Primaquine. Okay? What Primaquine does is it kills whatever's in your liver, i.e. Vivax and Valley specific. It'll kill everything else too, but remember, we don't know if they're in that area with Vivax or Valley, whether they've gotten infected or not, whether it's gone into a dormant stage or not. So the Primaquine is going to get rid of that aspect of the malaria. Okay? 14 days, 1 pill a day. So you'll be taking 2 pills, doxy and Primaquine, as prevention. Testing purposes, look, I don't think I'm going to test you on this thing right here. I am probably not going to test you on these 2 down here. So you just need to really remember Primaquine, Etravoquil, Proquinil, and Doxy for prevention stuff. Okay? Try to keep things simple for you. Okay, let's go ahead and take a break. They're going to give you slightly different guidance than what the CDC and the World Health Organization will tell you. Just keep that in mind. They may have access to something else that some other folks may not have access to. Follow higher guidance, go do whatever it is that you want to do, because you're going to find yourself in trouble. Okay? Here are some of the reasons why, and it shows 60% compliance. Right? I think that number is extremely high. Right? You give individual personnel stuff, you're not usually compliant, especially if you don't give them a good reason why. Okay? So when you're briefing these folks, make sure you give them the reason why they really need to take it. And there are some of the reasons that they gave the folks as to why they stopped taking it. GI side effects is probably the most common reason. So make sure you don't eat something before they take it. Right? That'll knock down the GI side effects. If they take it for more than 2 weeks on an empty stomach, usually the GI side effects start going down on their own. You can let them know that too. And their low perception of risk, that's based on what you tell them when you brief them before you give them the medication. I'm not going to test you on this slide. I go to the last slide, but just keep in mind that even with the Rangers, you have a very low compliance rate. This just demonstrates lower compliance rates, and even lower for both chemoprophylaxis, terminal prophylaxis, compliance rates. Okay. So we got to make sure that we let them know the reason why we're giving the post-prophylaxis. Okay, if they actually know why they're taking it, it's a lot higher understanding as to why. they should take it. But you gotta tell them that. Okay? That terminal prophylaxis there is the eradicate persistent hypnocytes, right? So that's the ones that go into the hepatocytes, into the liver area. Doesn't matter what species. If it's in there, that's exactly where the terminal prophylaxis should help kill. Liver stage for Valley and IVAX, especially if they go into the dormant stage, and Primaquin's going to take care of it. Acetaminophen, it says FDA approved, but we don't really use it here, and it's only directed towards IVAX. Okay? So we don't really use that. Primaquin is our main source. Okay? And remember, T6PD guys, you have to be very careful, but you may want to talk to an IV guy. Okay? You choose to give those guys Primaquin, because it is a finite medicine. These are the areas where Vivax and O'Malley hang out at, specifically. It's a little less than the other one was for all the other areas, but still quite a bit of the world, mostly concentrated in Africa. And your treatment indicators. And lots of quercetin, you should always keep. But really informing factors that you should do to treat that. So if you have someone with any Plasmodium species, treat. Okay? If they're infected with any other strains, just go ahead and treat. All right? If you have a clinical status patient, he's got stuff, he's got symptoms, go ahead and treat. Depending upon what the geographic area that they've been in is what you're going to use to treat. Okay? Coloquin resistant versus sensitive. That'll determine what medication you're going to use to treat. And then, were they taking their chemoprophylaxis? Okay? Have they taken any other malaria medicine to treat the malaria that they have, right? Because if they have and they have not gotten better, that automatically tells you that the medication that you're giving them for the treatment of malaria is not working. You have to use something different. Okay? Those should be your main factors for treatment. Okay, so here's some treatment. Okay. Prophylaxis drugs, do not use prophylaxis dose as treatment. Okay. So try not to use doxy if you need to. So here, it's broken out into two, coloquin sensitive and coloquin resistant. Okay? This is real simple. If you're in a part of the world where it is chloroquine sensitive, then you can use chloroquine phosphate. If you are in a coloquin resistant area, you have three choices there. Okay? Each one of those contains two different medications.
Question.
Yes.
For the test, are you going to be using POTX Maryland or chloroquine phosphate?
Say that again?
For the test, are you going to be using chloroquine phosphate or POTX coartem?
Chloroquine sulfate plus doxy. Atraloquine plus provoquinil or artemether and lumenfantrine. Those are the ones I'm going to use.
So the ones in question.
The ones in parentheses. The last one doesn't have parentheses, but that'd be the one that I would use. Same thing for the one on the top, it'd be chloroquine phosphate. Okay, if you end up with severe malaria, that would be falciparum type, most common. Okay, IV pertussinate is what you're going to use. This person needs to be in the hospital, so it's going to be an IV medicine. If you do have a malaria case here in the U.S., there's a reportable disease, you need to let the health department know. They will let the CDC know. Okay. Okay. What else you need? Supportive care is a big one, right? Supportive care. Monitor the treatment by doing thick and thin smears every 6 to 12 hours, because what you're looking for is that parasite load is decreasing after you start the medication. Okay? If it is not dropping, and here it tells you does not drop by 75% within 48 hours, or blood's not cleared or parasites after 7 days, then you may have to change the medications that you use. Okay? So we have to track of that parasite load to ensure that we are actually treating adequately. Okay? And that blood smear with microscopy, thick and thin, is that gold standard that we're going to follow. Okay. Treatments. Control glucose, managing acidosis, pulmonary issues, renal issues, seizures, edemas. Alright, so steroids, specifically with cerebral malaria, can cause hyperglycemia. Okay. It can exacerbate some of those neurologic symptoms that cerebral malaria cause by causing metabolic issues. And it can make stuff worse by delaying the parasite clearance. Because that'll slow down that immune response. Okay, so you don't necessarily. And then as of 2013, we initially thought we could do blood exchange and transfusions with these malaria patients when they have high parasite loads. But according to the studies, they haven't had any proven benefit, because there's no proven benefit, and it is a very invasive procedure with high side effects to it. They don't recommend it. And now that we have IV or tensionoid, that medication itself has been giving folks great outcomes. Okay? And it's not as invasive as putting someone through blood transfusion or exchange. So we no longer do that stuff. All right, so thoughts on reoccurrence. If you do have relapse of malaria, the likelihood of it being high-vaginal valley increases drastically. Okay. Recrudescence just means it's a reemergence or recurrence of symptoms of the disease after a period of improvement or remission. So sometimes what happens is that people get partial treatment for malaria, they still have a small viral load left, but they have no more symptoms and they think they're good, and they may stop the medications. But then the viral load starts building back up and they end up getting sick again. That's part of the problem. The other part of that problem is that we give them medications to treat them, but we give them the wrong medications. We may give them a coloquin medication when they're in a coloquin resistant endemic area, or they picked it up in a coloquin resistant area, and it's not going to do anything for them. And there, if you look at the bottom, P. malaria, persistent infection below detectable levels for 20 to 30 years. So that one, as we mentioned before, propagates really, really slow. So it may hang out in your body for a long time before it actually causes you problems. So here, they've got sickle cell disease is not, it goes back to your question earlier, sir. Sickle cell disease is not a protective factor in malaria. Okay? One of the top precipitating factors of sickle cell crisis, right? So with sickle cell disease, there's lots of things that put you into crisis. When you go into crisis with sickle cell disease, all your blood cells start going into this sickle shape, right? Hence, sickle cell disease. And malaria can do that to your red blood cells. And when you start doing that, you start causing microthrombi, you start damaging organs, you start causing a lot of different problems. But initially, we did think that that was a protective issue, but it is not. The trait is a protective issue, not the actual disease. The disease is basically a mutagen in the beta globulin gene the individual person, which is why they end up with sickle cell disease. So here's your little chart. If you look at HPAS, which is one on the top, that is your sickle cell trait versus your sickle cell disease, which is one on the bottom. Okay, your sickle cell trait has shown to give you some protection versus your sickle cell disease, which has not. So there's a pretty huge gap between the trait, which is the pink one, and your disease, which is the brown one. Okay, this is more of a spec slide. Right, it's not just endemic areas anymore. It's now travelers that go to endemic areas as well. Probably not going to be tested on this slide. Remember, it's an Anopheles female mosquito. Here's some more stats with 35 people in 2019 with malaria. 5 IVACs, 19 falciparum, 11 unspecified.